So we're gonna jump into the question and answer now. Look, I moderate this kind of stuff on a monthly basis in a different program. Usually I have 2 to 3 other speakers with me. Today, I have 14 participants here, so I'm gonna do my best to try to make sure that I get all the right participants trying to answer the questions. So hang in there with me and we're gonna try to get this done. So we're gonna go through, I've got 3 pages of questions and then questions slowly coming into me one step at a time. So I'm gonna take the questions and try to feed them out. Please send them in if you get a chance. You can email them to team@painab.ca. That's team@painab.ca. You can text it into 780-457-5225. That's 780-457-5225, and it's right here at the bottom of your screen. You can also tweet it at Alberta_pain. You can put it onto the Facebook. We will figure it out, or you can put it right here on the text chat. And we've been trying to copy all of the questions on the text chat. It's all been sent to me, and I'm gonna kind of go from there. So our first question, discuss the use of ketamine infusions in Alberta, access, efficacy, US models, etc. I've had physicians tell patients, so that there's just 2 questions here. So I'm gonna start with that one. So ketamine, so I'm gonna start with our pharmacist and have Christelle respond to the use of ketamine in pain. And then I'm gonna jump over to our sleep specialist and ask about ketamine and its impact on sleep. So I'm going to just jump right over to Dr. Kullar, talking about ketamine itself and your knowledge there, and knowing, look, ketamine has more and more evidence in treating depression and improving outcomes in depression. It definitely has evidence in pain. Are you concerned about sleep, or is this something that you see being?
That's a good question. I'm glad you brought it up. Very timely. No, ketamine is very useful for sleep because it's treating the pain and the mood, 2 things that a lot of people with chronic pain suffer from. It can be done IV under supervision, nasally, orally. There's a strong history in Alberta, and I would really encourage all the patients and advocates on the line. I'm actually consulting right now with a group of Ontario physicians. The college wants to control it quite rigidly and deny, to be honest with you, deny you access to ketamine for very spurious reasons. Yes, there is some abuse potential, but it is a great underutilized treatment. Mood, sleep, pain. I see you grinning in agreement. And luckily, our Alberta College is very reasonable about it, and hopefully will stay that way. But it is a very good option, especially if there's some mood symptoms. It's emerging. It's fair, especially orally, it's fairly safe and well tolerated. And I would encourage you all, especially if you're on Ontario, the colleges really want to be draconian there, and BC as well. And we need to start fighting
that. Thanks, Dr. Kullar. I completely agree. So, I got to say the college here in Alberta has been looking at this and how to run this. They've asked me to join kind of a committee looking at the efficacy and benefits and harms. I have to say I've had really impressive outcomes using intranasal ketamine and have found it to be quite impressive at both treating the mood and the pain. And if you can imagine someone struggling by both pain and depression, and suddenly both of them start improving at the same time, it's pretty impressive. Now I know Tracy raised her hand here, and I would love to pass it over to her because Tracy, and we've actually had these conversations about ketamine and some of the problems we're having where some of our ketamine clinics have closed and trying to figure out what to do. So I'll pass it over to Tracy from a patient experience.
So yes, I use ketamine. I can't believe I said that out loud because not too long ago, I was actually afraid of it. It had come up in the past and I had avoided using it. I think I had a preconceived notion that was going to be some nasty thing I was going to have to give up at some point. But honestly, in my life, it made a huge difference to pain that we couldn't control another way. So I suggest that if patients out there are introduced to an opportunity like that, that they seek out information before they reject the opportunity because they may miss out on something. As an advocate, I am fighting very hard on that front because we cannot afford to lose potential treatments without very serious input from professionals and patients.
Thanks, Tracy. One of the nicest things, so I use one of the American intranasal protocols. I get it compounded at a pharmacy and get them to use it that way. It's actually a U of A psychiatry clinic that I got some of their protocols from as well. I know there's sublingual protocols. One of the keys that we do is it often doesn't need to be used daily, which is really quite amazing. For many people, it's a couple of times a week. So really, there's a lot of evidence that it's got really good outcomes, especially in acute pain post-surgical areas. There's lesser evidence in chronic pain, but we know it's there. Certainly more and more evidence building up for depression. So there's no question that this is something that we'd like to see and we'd like to see more often. And there happens to be a few of the pharmaceutical industries looking at bringing it into the Canadian market. So I think that this is going to be more and more of an accepted protocol. The way I kind of look at it, if we've tried other mechanisms and nothing's working, I'm more keen to look at using ketamine than I am looking at chronic opioids. That doesn't mean that they don't end up being used together or other formats, but I would certainly look at it in that process. A second question that came in was about ending benzos cold turkey. As a pharmacist, I would protest such a thing. And why would a physician ever stop someone cold turkey from benzos? I would add, don't ever do that for opioids either. That's a horrible thing to do to someone. So I'm gonna now, as this is a pharmacist protesting and our pharmacist is back, I'm gonna pass this over to Christelle and talk about what you do in counseling your patients when they come in to fill their prescriptions about benzos.
Hi, I think this is working now. Really good question. And I think just like any medication, there are discontinuation type syndromes and really harmful ways about going about this. So I think the key thing is to work with your team, especially with your family physician. What are your reasons for stopping it? Is it a switch over or is it actually completely coming off of that? And it has to be slow and gradual and very individualized. And I would do this with your team. I would do this with other strategies in place. In addition to just stopping the medication, no, gradually reducing and having other strategies in your toolbox, which we've mentioned about, to be available. I don't work in community pharmacy right now, but I do know, if this came from another fellow colleague, the key thing is that we have to all work together. So it's the community pharmacist, it's the prescriber, it's the allied healthcare professionals that are involved both privately and in primary care. Anything else to add, team?
I would just throw in, just from a sleep perspective, most of it, we talked about deprescribing not being necessarily stopping, and I think that's similar for benzos. There's a lot of overlap. It needs to be done slowly, consistently, and what I find with tapering it, you may not always be able to stop it, but you can almost always reduce the dose. And I think the number one goal is just to try and reduce the dose and see if we can taper it, and don't get scared by it. So if your team is not doing this in a slow enough fashion that you're comfortable with, you need to kind of address that, I think would be my key point, because it can be done, but it needs to be done slowly and with supervision.
100% agree with that. In fact, it's unethical to do it any other way. Simply stopping it is simply unethical and does not follow any evidence in support of doing such a thing. Okay, moving to the next question. And I'm hurrying this a bit. I know some of you may want to talk, but we have a lot of questions. So many of my patients are overweight. They say they can't exercise because of pain. Any questions? So I'm gonna start with Alex on this one.
And that's a question we get a lot. And I think it comes down to a conversation with the patient, what's going to work for them. and finding out where we can start. Because if people can imagine starting and finding a way that works in their life, we can work with them. So we can always start somewhere. And I think it goes back to what we heard Tracy say today. The goal is not to get up the mountain. The goal is to start the journey. And so it's figuring out a way together that you can start that journey. And that would be my sort of suggestion is it's not one size fits all. There's no particular recipe, but it's figuring out where the patient is and just slowly working towards that goal. Not sure if that was helpful.
Absolutely. Can I get any of the other movement practitioners to jump in on that?
So this one really makes me think about whose goal is it? So just to kind of reframing it, I know that weight loss is a really important thing, but most often people would make their goal something a little bit more in line with their values. And so if weight loss is going to move them towards that more important goal to them, then it all starts to make sense. I think sometimes we do have this tendency as healthcare providers to just jump in and say, okay, here's what you need to do. And we need to kind of back up a little bit and make sure that's actually meaningful.
Well said. There's absolutely no need for us to be trying to take our values and putting it on someone else. It really has to be where someone else is coming from and helping support them. I say that to people all the time in our clinics. When they apologize or I didn't, it's, whoa, wait a minute. My job is just to be here to help and support you. There's no shame, there's no guilt, there's no judgment. We're working with you to do this. And so if you ended up only walking 3 times this week, that's awesome. I mean, 3 times is amazing. So what, you didn't make it every day. Maybe next week we could do 4 times. Let's just take it step by step and follow what you want to do. I'm curious on a patient perspective. I hate using the word patient. Somebody with experience of living with pain. What your thoughts would be. So I'll start over with Tracy. Your thoughts on doctors telling you to exercise.
I think exercise, it's such a scary word because every time, if you think about it, somebody says exercise, you think of going to the gym, you think of lifting weights, you think of running on a treadmill, and that may be so far beyond us. I think motion, bodies were meant to be in motion. If you cram a body into a tight box and leave it there, it will hurt, even if it didn't have chronic pain before. And I think we need to change that language. It may turn into exercise, but let's start with a language that doesn't scare us off. And on the weight thing, I think one of the reasons why patients bristle at the weight conversation is because, again, it often comes with, well, you should lose weight, and that's the whole plan. And let's face it, you can get fibromyalgia if you're not overweight. It may be worse with the extra weight, but it shouldn't be used as a way of blaming the patient for their pain.
Perfect. Thank you. I love that part. We don't shame, we don't blame. If you're doing that, you're doing a disservice to your people and to your practice. No matter what you do, I don't care where you work and what you do, we just simply don't do that. Again, taking it from I would love to hear again from another one of our physios on that. So I'm gonna just pick someone. Stuart is ready to go.
Sure. Thanks, Rob. So I think what's helpful or has been helpful for me is 1, finding things that are meaningful for you, but 2, sometimes if practitioners talk about thresholds, you have to or you need to do this much. When I look to the evidence, which is really helpful, is any activity is beneficial. So, and often the people who haven't been doing much, when they start, they often notice the most benefits. But again, it's finding a way that you can do it that's safe for you and that you feel comfortable starting. And I really appreciate what Tracy talked about in terms of how we look at our unique situation and how we move forward.
Perfect. This is my biggest thing is that we actually, one of the other physicians has a prescription pad for movement and exercise. And we always listen to what someone can tell us, like, what do you think you could do? And do you want to, of course. And then we start with that, and we find just having that prescription just kind of helps somebody and supports somebody in kind of following suit. Okay, moving to the next question. Do lectins play a part in inflammation? Dr. John Pereira.
Thanks for that question. And I want to begin by thanking you, Rob, for your vision in putting on this day. It's really inspirational to see this take shape. Now to the question of lectins, which are very popular. A lot of people have been talking about them. Lectins are found in many plant substances. There is a debate as to what they do to human health. Most experts believe that lectins are good for your health, and the consumption of fruits and veggies, which are filled with lectins, play a role in making you feel better and healthier. For the small number of people who may be sensitive to certain lectins, there are approaches that you can take. For example, with heat, you can destroy certain lectins. There are some people, for example, who will use a pressure cooker for those kinds of foods to reduce the content of lectins substantially. But long story short, lectins tend to be very good for most people. They seem to promote health. Can they have effects on cells and kill certain cells? Yes, including cancer cells, for example, which might be a very good thing. Rob?
Thank you. Is there anyone else that would like to comment, or even just comment about how diet fits into your practice and what you guys do? Not all at once. So, I mean, I have John all the time. He's sitting here for me, but he could be somewhere else on your screen. I have him all the time. So when I have a question about diet and inflammation and all this stuff, I always have an excellent resource, and I appreciate it very much. Next question was, there were some resources that Claudine mentioned, but they may be expensive. Is there any way to access these resources if you don't have the resources to do so? Or are there free ones that you can make suggestions for? So I'll start with Claudine and pass it on to the rest of them.
Sure, thanks Rob, and thanks for the question. I'm trying to think of anything that I have paid for. My supports have come through the opioid deprescribing program, which is free out of the Sheldon Schumer Center, or through the pain clinic. So I haven't had to pay for anything that I've mentioned. That being said, I did do some work with PTSD support, and that is something that I needed insurance for sure. But I'm just kind of going through and thinking about this. The dialectical behavioral therapy was through the ODP program at Sheldon, as was the cognitive behavioral group. Sexual health was through the pain clinic, and the vitamin discussion that I had in hydration came with my GP. So that was free. If there's a specific thing that I mentioned, let me know, but my PT, massage, all of that came through programs so that are sponsored by the province.
Thanks, Claudine. I mean, there's a problem with pain, and it's been here for a long, long time. I can't comprehend why we have no problems covering medications and nothing else. And we know that the treatment of pain, that's my daughter, is a biopsychosocial format and sometimes spiritual, and it counts for all pieces. I'm going to pass it over to Safa, who has been asking if she should just interrupt, and the answer is yes, just interrupt.
Sorry, okay, I'm not muted. I just wanted to say a little quick thing on movement. So I am a physiotherapist, so obviously activity and movement is quite important. But with my pain patients, one of the first things that we talk about usually in the first session, I ask people about joy. And I basically just ask people to make a list of what brings them joy. And then I kind of piece movement out of that. And so I start from a place of joy and then see where that takes us with movement. And that's just my practice. But just like everyone has said, I really feel like it has to come from the person's life and their priorities and their values. That's all I wanted to say. Thank you.
Thanks, Safa. Okay. Any other comments on exercise or psychology or all the things that aren't covered? Here's a chance to be an advocate about this.
So you know, Rob, that I fight to get those resources for patients across the province. I mean, I really do, because we know that not every patient gets to a pain clinic that has them. Not all of them have insurance that covers them, and they are costly. One of the greatest tools in my toolbox was biofeedback. And right now in Edmonton, I think it's $250 an hour and not covered by most insurance companies. What I do want to say is that if you are looking for some of these things and you can't afford them in the traditional format, then reach out to some of the social media groups, some of the support groups out there, reach out to your PCNs, reach out to social community organizations and see what's available. And sometimes we can get pretty creative about piecing together something that will get you started without that big expenditure. We shouldn't have to, but that's what we recommend.
What we need is like 1,000 Tracy's across the country, and then they can connect you to everything. That would be amazing. Bonnie, you had something.
Yeah, I'm not sure if people have heard about this, but in Alberta, Alberta Health Services has set up a rehabilitation advice line. So if you go to the Alberta Health Services website, you'll find the 1-833 number, and that will connect you with an OT or occupational therapist or physiotherapist based out of Calgary. But I know that throughout the province, nobody knows where to go or what services they can get. And so that's a great central place to go. And it's probably something we should have had before. So great idea and a good innovation that we've had.
So what we'll do, we will tweet that out. There is that number, and I'll get that tweeted out. I know Tracy Wasilak, one of my co-chair, I feel like I'm more her co-chair, co-chair of the Alberta Pain Strategy, is one of the people leading this up, and it is out there in Alberta. So I'll definitely get that tweeted out. Perhaps Sylvia, if you're listening, you can track that down and tweet it out for us right away so people can see it. I'm sorry to keep moving on, and I know everyone wants to talk, but this is a really quick question and answer that I can do. What is the name of the person heading up cannabis in the 21st century? So that is Sunil Rajput. So he's from Alberta Innovations. I believe he's out of the University of Alberta. You could probably just Google Alberta Innovations and take a look at that. I'll also make sure that we tweet out that slide so we can get more information there for you. Next question. This is a long one, and I'm gonna try to tackle this, but I'm really going to need Claudine and Tracy to help out with this. As someone living with chronic pain for the last 8 years, I've been fortunate to have learned early on to let go of the over-identification with my pain. Chronic pain is something that I am experiencing. It is real, however, it is not mine, and I prefer to live without the chronicity of pain. I've been reading a lot about mindfulness, and John Kabat-Zinn speaks about over-personalization of pain, which can create more suffering and prolonged pain states. Reading the title, Let's Talk About My Pain, and I'm going to own this one, doesn't resonate with me. I find that it reinforces to my nervous system that pain is a part of my identity. How do we change the attachment on the personal pronoun of my pain? Do you see any benefits of the change as often taught in mindfulness-based stress reduction? I'm going to apologize. So we initially had it called Pain Day. I actually sent it out to a few groups as kind of focus groups of people living with pain, including Tracy and Claudine. I also sent it to our advisors that sit on the Alberta Pain Strategy Steering Committee. We have a few patients on there, also got there. Everybody really liked the change from Pain Day to Let's Talk About My Pain. You're absolutely right. And I would actually agree with what you're saying. You know, it's sometimes so hard to come up with ways to do this. We could have just said, let's talk about pain. But we really wanted to enforce in the title that this was about people living with pain, not about the practitioners learning about it. I'm going to pass it over to Tracy or Claudine if they wanted to tack on to this. Claudine, you're first.
Yeah, thank you for this question, this comment. It's very important. You know, we're sort of taught very early on how people define us. And I think as human beings, we have the ability to define ourselves. So that's where we need to have that conversation. And that's why it's really important to continue the conversation about pain and what that is, because everybody in the world, for the most part, feels pain at some point. And it doesn't define you unless you choose to have that be a part of how you want to define yourself. I think for me, I focus on other areas as a woman, a professional, a mother, a spouse. Those are all things that matter to me. And yes, I happen to live with pain. I too don't enjoy the concept of chronic pain. I don't want it to diminish somebody who has short-term pain or pain that isn't continuous all the time. It's pain. It doesn't matter what, you know, how you call it or how you define it. And so those are conversations that we need to keep having. And I appreciate you bringing it forward. But I'll turn it over to Tracy because she's got a lot more experience in working with individuals with pain. And I think she might have some great perspectives for us.
Thank you. And tough question. You know, I don't think that it is healthy in any way for us to over-identify with our pain. Absolutely. But I also think that we can't pretend it's not there. And for many people, the first step is what I said about acceptance. It's kind of like if you want a house, you have to accept that there are bills and that you need to do upkeep. Otherwise, things fall apart down the road. So the first step for many patients is identifying, I have this thing, but it does not have me. And from there, they start building the ability to separate it from them or part of their personality or identity. And it just becomes sort of like, I have brown hair or I wear glasses. But if you are at the point where you feel you have become too entwined with it, it's time to sit down and think really carefully about who you really are. Who do you want to be? What do you dream about? Because you know what? It is just a small part of who you are. Maybe a big chunk of your life, but just a small part of what makes you you. I know that for me, I realized after a very long time, my chronic pain made me strong. My chronic pain made me a warrior. It made me a fighter. It made me capable of appreciating things. And so it is not an evil for me. But I think we each need to be honest with ourselves about that conversation and where we are on that spectrum.
Thank you so much, Tracy and Claudine. I don't know, Elizabeth, if you want to talk about kind of the psychological indications in this from a kind of a psychologist viewpoint. And this is a big piece in acceptance commitment therapy. So I'll pass it over to Elizabeth.
I think one of the challenges is we don't live in isolation. We don't live in a bubble. And when we're talking about ourselves over-identifying with pain, we also need to recognize the context we live in. And when you are a patient or client, sometimes every conversation you have when you go see your doctor, when you go see your physiotherapist, when you go see your massage therapist, your pharmacist, it starts with asking you about your pain. So again, it's partially being that mindfulness of recognizing you have to acknowledge it, you have to answer those questions. But sometimes it's also you setting those boundaries of, letting your friends know, enough about me, let's not talk about that. Or saying, what about you? What's going on with you? Or shifting that topic so that you can focus on other conversations. But sometimes it is about having to kind of take control of where that conversation goes. Because sometimes it's hard when our entire environment ends up, like we said, sometimes what the society tries to identify us as, and we need to own what we want to identify as. So rather than letting other people dictate that, controlling that conversation and sometimes setting those boundaries, whether it's with family, friends, or even with your healthcare professionals, and making sure that your voice of your identity is getting out there.
Thank you so much, Elizabeth. I think this has so much to do with language. And so, again, I sent it to a few focus groups and we tried, but my apologies. I 100% agree that one of the biggest things that we work on in our programs is about, acknowledging that, yes, I have pain and accepting that, but also acknowledging that I am more than just the pain. And so I certainly didn't mean in any way to have it come across that way. And thank you for bringing it up to us, as that will change our next title coming up. So we'll figure that out, and I'll rely on some other people here to help me out with that piece. Next question, wondering about hydrodissection with dextrose PRP for chronic pain. Had anyone seen success with this treatment? I think I'd actually like to shift this over to some of the physios. Do you have patients that are undergoing PRP, and have you had good response in watching them as they do so? And by physios, I mean any of the manual therapists here.
I'll talk because nobody else is, but we don't use it here, and I haven't had experience, so I'm good.
Okay. Okay, out of time, so I'm gonna now pass this over to Dr. Pereira and get kind of an expert point of view from a pain physician.
Thank you very much, Rob. So when you think about hydrodissection, we're thinking about how certain tissues have injury or inflammation, and that can cause them to adhere together. Hydrodissection using a fluid to separate those layers is something that can help people. At the same time, it can often increase inflammation before it decreases inflammation. And so when we think about procedures and we try to look at them in terms of risk and benefit, it is important to note that any procedure can make you worse, either short-term or long-term, and hydrodissection does have some of those risks. In short, has it helped some of my patients? Yes, it has.
Perfect, thank you. So moving on to the next question, and it's a difficult question, and it's a question about mental health and pain, and we can add that into sleep as well. Some people feel very stigmatized that mental health and pain are interlinked. I'd like to start by saying quickly, and this is a lecture I give all my patients, we are our brain. We think we see with our eyes, but our eyes just take photons of light, turn them into neurochemical impulses. We see with our occipital lobe. We hear with our ears, but actually our ears just take sound waves, turn them into data. We hear with our brain as well, and we feel pain with our brain. And we feel emotions and present emotions with our brain. We are our brain, and our vehicle just is our body to get us around and to manage our environment. So as much as we are our brain, there are ways that mental health can affect how we feel pain. It doesn't mean, and I strongly say this as a psychiatrist, it doesn't mean that, when we start looking at depression, or we start looking at anxiety, or we start looking at coping skills, that I'm saying the pain is in your head. But everything's in your head because it's in your brain. But pain is real no matter what, whether there's an MRI that can see it or not, whether there's an X-ray that can see it or not, or whether it's physically in front of us, like something like CRPS or not. Pain is real, And that is the way we should be approaching it. And then, of course, depression is real, and we should not have a stigma towards mental health. Trauma is real, and these are treatable. And insomnia is real, and it's treatable. And if we start treating all the facets rather than focusing on one little pinpoint, if we treat the sleep and we treat the depression and we treat the trauma, invariably one's pain will get better. It doesn't mean it'll magically disappear like some sort of a magic wand, but it will make it easier to deal with and to cope with. And so I've actually had these really good conversations with Tracy about this. And in full disclosure, I also have chronic pain. So I've also been on the other side of the boat, and I know what it's like to feel the stigma in healthcare providers and emergency rooms and urgent cares. I also know what it's like to hurt and not get off the couch. So when people say you don't know what it's like, I do. And with that piece, I also have seen when we treat the mental health and we treat the sleep, we do see significant outcomes and differences. But when a practitioner says, oh, well, you're depressed, you have to fix the depression, we have to change the language. And I think that's one of the important things. And I think that's true when somebody's seeing a physiotherapist. The language means so much. When they're seeing their doctor, the language means so much. When they're seeing their psychologist, the language means so much. And I can't apologize enough for our healthcare system. And the reason I work in pain is because of my own personal experiences. And I get it, and I understand what you've gone through, but at the same time, that doesn't mean that we can't treat that stuff. And it doesn't mean we shouldn't focus on it. I've had patients literally, and lie is a strong word, and I don't mean it in a stigmatizing process, but they just don't want to talk about how their depression is affecting them or they'll just simply lie on their questionnaires because they don't want to deal with it. And then after we get to know each other, we start digging into it and realizing there's so much more here. And that is really what an interdisciplinary team is all about, is to look at all of it, not just one piece. I know I've really picked on Tracy and Claudine, but I'm gonna do it again, and really looking at it from somebody with lived experience, what this looks like to you, both when someone starts telling you that you need to do things and how important it is, or what your thoughts are about mental health. And then I'd love to get a response from the other psychiatrist and the psychologist on the group as well. But people first. So over to Tracy or Claudine.
Okay, I'm going to step in here. I'm going to ask a question of the people and the patient in the chat group. If you really recognize that when there's a death in the family or financial stress or emotional stress, that it impacts your pain, I want you to hit number one in the chat. If you don't think it has any impact, hit number 2. And I bet what you're going to see are these patients are going to flood it with ones. We're not oblivious to the fact that our emotions impact our pain. In fact, it is a common topic in social groups and support groups. The fact is, the issue of bias and judgment and stigma is there. We already have a label of chronic pain that puts us in a position that is often adversarial with the medical system. And now you want to add mental health on, and suddenly it's like nobody will believe you again. The other problem is that for most of us, at somewhere down our journey, we have experienced somebody saying it's just depression, or we'll treat the depression, and if that doesn't make the pain go away, then, or saying it all started from depression when we know full well it didn't. There's a need to have honest communication. There's a need to feel safe in the medical system. And there is a need to change the way we dialogue about this, because you know what? We get it. We know it impacts us.
Couldn't agree with you more, Tracy, on this. This is a big conversation, and probably one that needs to continue after today. But, I've suffered from depression since I was a teenager. And, I was lucky enough to find a support team that understood understood dual diagnosis and being able to discuss that with me in a very open and transparent way. That's not the case for a majority of people, and that didn't happen until after 20 years of me trying to have a conversation. So it's one of those things where we need to as patients and as people living with pain, we need to understand the importance of being transparent and open, and we need to figure out a way to not come from a place of shame, because that's been our experience, unfortunately. And, I think the other thing too is when we find some great practitioners out there, thank them for what they're doing, because they're doing a hell of a job. And I'm grateful for people like yourselves that are all on this, presenting today and listening in. We couldn't do this without you, and we need you, and we need to work together. So it is a bigger conversation, but Tracy, you said it so well. Thank you for that.
Thank you to both of you. I do appreciate it. Look, I mean, Dr. Kular, you see patients all the time for sleep. How often do you invariably end up having to talk about pain and talk about mental health?
I would say good 3/4 to 4/5 of the time. And I think to me, it's interesting. I find the pain is downgraded, and the mood and anxiety. And so I think sleep is a good, because I do sleep, I do mood and anxiety, and I do chronic pain. And they usually come to me not sleeping. And it's quite clear very quickly that their pain has not even been close to optimized. Right. So I'm like, well, it's not really, I can give you some suggestions, but these are the tires, not the engine. And a lot of people have an experience, oh, it's just your depression, oh, it's just in your head. And the language part is very critical, which is why in my presentation I said these are central sensitivity syndromes. Like you said, Rob, everything goes to the brain and it's all manifestations of the same thing. And we have to find the right things to tweak. And this is why, whether it be sleep, whether it be mood and anxiety, whether it be pain, and it's difficult. I find the limiting fact is getting our messages out to the healthcare system, period. People who are interfacing with, like, I'm sure a lot of you on the call have had years of struggle trying to be heard, years of struggle, largely because you were locked in a box, right? And that's where the change needs to happen. Like, I think you as pain patients doing all you can most of the time, right? We need to look at this top down systematic change of how this is accessed and dealt with, and there's multiple things to that. But I think the thing is, I would sum up with, if you are not sleeping, all the points are not you know connecting, right? And so it's, for example, if someone says, oh yeah, it's just your depression, and they treat your depression, you're still not sleeping, well, there's another factor. If your pain is being treated and you're still not sleeping, well, there's another factor. It's sort of, at the end of the day, if you're not sleeping well, something is not right. And looking at all these different points is important, but doesn't sort of get done with the system.
Excellent, Elizabeth.
So I think one of the priorities that we need to have, and this goes everywhere top down, like we're saying, is that we need to recognize that mental health has the same value as we've placed on physical health. And I think part of the stigma lies in the fact that when we say we have a mental health problem, that we also don't talk about it like there's recovery. Nobody has shame or judgment about walking in to see a physician. And they shouldn't feel that way about going to see about a psychologist or another mental health therapist. You should embrace it, and you're going to address something, and they are part of the team. But when we talk about mental health, often it gets labeled, as we talked about, like you're broken. And if we always focus on being broken and we don't focus on the fact that there is recovery, whether we're talking about trauma and it's very treatable, we need to stop putting limits on people and acting like because they're having symptoms, this is the end of the road. And mental health, I think, obviously is on the front of everyone's mind. It's gotten a lot of media. Now we need to move it forward so that it's accepted, so that people feel comfortable having the conversation about it. People feel comfortable seeking recovery from it, and people recognize that it's a part of your overall health and it's just as important and should be treated as such, both as individuals, but also from a government and a funding standpoint.
Hear, hear. Let's keep advocating for that. This is actually a really good question, and I'm going to choose who to pose it to in a second as I'm rambling. The question really comes down to pain flares. So, you know, there's pain flares with menopause, there's pain flares for unknown reason, there's pain flares due to weather, there's pain flares because I overdid it. I'm curious that they're asking what to do about it and how to deal with menopause and how to deal with pain flares. I actually want to shift this over to people who are manually treating chronic pain. How do you approach it when somebody comes in and their pain has gone up or they're flaring upwards? And what is your approach to that? I'll let the interrupt method work this time. Okay, Erica, you got your hand up.
Okay, so I tend to see this a lot because the people I work with tend to have a lot of chronic pain, and it's not just one thing that they have going on. It's not, I have one symptom, it's I have 27 symptoms. And when they have a pain flare up, it sends them into panic mode. And so the first thing that I usually say to them is, you are sending alarm signals to your brain. And your brain's response to that is going to be ramping up your pain even more. So I know it's hard, but the best thing absolutely you can do starting out with is to try to stop panicking. And remember that your brain sends out pain as a defense mechanism based on how much danger it thinks you're in. And so if you're doing self-talk to help yourself with that, regardless of where you are in your pain journey, what mechanically is going on and that sort of thing, you can always help yourself with self-talk to start out with. And I'm sure Tracy has done this millions of times before. But, okay, so this is not a great day, but there are things that I can do. What is my list of things that I can do to help calm myself down and keep this from being a panic situation? And then go through your list. Go through your list of, okay, do I need tea? Do I need more meds? Do I need different meds? Do I need a little bit of movement? Do I need somebody to do something for me? Do I just need a day in bed, or do I need a distraction? Do I need somebody to give me a massage? All of those different things, but having a plan and working your plan so that you're not just caught flat-footed in panic mode with nothing to do.
Anybody want to top that up? I couldn't agree more with everything you just said. I would want to add one little piece. When we go into pain flares, we become distressed. And what do we do physically when we become distressed? We tighten up. What is the worst thing for pain physically? Tightening up. And so this is where all the work that we do in kind of DBT skill set, acceptance commitment therapy, mindfulness, is realizing where your subjective units of distress are, catching them before they go too high, and using skills to bring those down nicely. Because if not, our distress will lead to a pain flare. And this often happens, and we kind of miss that piece as we end up trying to treat it afterwards. And this is where a lot of the work of learning about your body, about your emotions, about your thoughts, and how they affect everything and how they can lead to tightening up, which then leads to more pain. I mean, most of our medications do the exact opposite of what we're talking about, but there's lots of ways that we can learn to do that without. Another comment, Bonnie, please. And then Safa after.
As an occupational therapist, I work a lot with people on preventing flare-ups. And that's really important, trying to learn how to pace and prevent. But this is an important message. If you are living your life and if you're doing what's meaningful for you, there are going to be flare-ups. And just recognize that's what it is. It's a flare-up. It's going to get better. This means I'm doing the things that matter to me. You didn't fail. It just happens. And that was just, I wanted to add that because flare-up isn't necessarily doing something wrong.
Thank you, Bonnie. I agree with everything that Erica and Bonnie have said so far, and of course everyone else. But so I used to work at the Chronic Pain Center, and one thing that we always did is create a document that's a flare-up plan, and it's using everything that you know, but there's a real solidity and validity in writing all of these things down, because we all know when your brain and your body are in that anxiety or panic mode, sometimes it's difficult to organize your thoughts. And that is a very physiological thing. It's a very real thing that your higher centers feel a bit disconnected from your feelings. So when you are in a place of your pain is managed well, to write down all of those things that would help you in a pain flare and have them available. Like just put flare-up plan on the top, stick it on your fridge, and then when you are in that moment of anxiety or panic or increased pain, you can just look at your list and you don't have to think. That's all.
I want to cut in for just a second and add to that. You know what? She's very right, and a lot of us don't ever do that. But I can tell you, I was in one of the worst pain flares in my life for 48 hours, and I forgot to take my breakthrough meds. You know, that quick thing that's going to take the edge off quickly. I forgot to do that. When it comes to pain flares and managing and getting through pain flares that come from daily living or doing the things that we do, maybe not the peak panic ones, but one of the things that I teach and that we use at Help Alberta is I earned this pain. We approach it with kind of a cocky, in-your-face pain attitude. I did this despite my pain. I am proud of it. I earned the pain I'm in, because I know that if I didn't do that thing that I love, that I would still have pain. It just would be really for nothing. And this pain, it's mine. Back to you.
I love it. I honestly teach that every day. You know, some people will go through programs and they get taught to pace and they end up doing nothing. And then, you know, I'm like, well, why aren't you doing anything? Because if I do anything, it causes pain, and the clinic told me not to do anything that causes pain. I take the exact opposite approach. Do anything you want. Know a consequence, unfortunately, in your life is pain, but you got to earn it. And we talk about earned pain all the time, man. I feel like Tracy's been in my clinic, but she hasn't. But that is exactly what we talk about. Like, you know, I'm going to do things I know I'm going to hurt. I know, you know, I'll walk 18 holes of golf, and I know that's not super strenuous, although my iWatch tells me that's about 1,000 calories when I do it in a valley course. Anyways, when I walk 18 holes, I know that night my feet are going to crush and I'm going to be in pain and it's going to suck and but I don't stop golfing because of it. And I think that's something that we really need to talk about with people is the role that we should be focusing on is empowerment. You can live a really good life. It just might not be that life it used to be. And so many people get stuck in what I used to be. I'm not 21 anymore. That's when I first went through my stuff. I'm not 21 anymore, but man, I'd be really grateful to be 21 again, partly. I don't know about 21, but anyways, you know, earning your pain and empowerment and being proud of who you are and acknowledging like, I can do anything I want to do, and there's going to be limitations. I remember one young patient of mine stopped skiing with his kids and was like, well, why? Because at the end of the day, I'm a disaster. Well, have you thought about just doing an hour and spending some time at the chalet or the mid thing and maybe the last hour of the day and you're still out there with your kids? Amazing that one little thing was life-changing for you. And so we can't just give up and stop doing it. I love Tracy's comment, earn your pain. We're going to do one more question. We are so far over time. It's 2:21. We were supposed to stop at 2. Thank you to everyone on the panel. Nobody's bailed on me. Every once in a while, I wonder if someone's going to be like, okay, you booked me till 2, but you guys are amazing. I actually want to do 2 more questions because they're both actually really important. One is actually about CRPS. In my opinion, one of the most devastating chronic pain syndromes there are. I'm going to kind of do around the clock. I want to start firstly about CRPS and centralization of pain. I'm going to pass that to Dr. Kular and then over to Dr. Pereira. Then we're going to shift over to what do I do for CRPS? Is there things that I can do about it to try to improve or make my life better. And I'm going to move that over to some of the practitioners. So starting with Dr. Kular, specifically about that sensitization and central aspect.
Well, yeah, that's a good point. And that's kind of what a lot of these things are, and that just sort of has the sort of formal diagnosis. I think for that, it is critical that every other piece has to be optimized, right? Because that's going to be the elephant in the room. So if you are, it is even more critical to take care of your sleep, for example. It is even more critical to take care of your mental health. And I would say this to anyone who's lived with chronic pain. It is more critical to understand how you got there, your psychological makeup. And, I think we've talked a lot about trauma today, and I'd like to, throw that back out there again. Is, we all know that, early child experiences, trauma lead to these things. And you may not be able to, or have the resources, or need to kind of go through every little bit of it, but just understanding, to me, the sort of what your triggers are, the expectations, all these things would be sort of the first step, and making sure that everything else is optimized and every part of your treatment is working. Because what I see with a lot of CRPS patients is they're over medicated, right? Having tons of side effects, which are actually shooting thing in the foot. And, I think using things judiciously for all these other points is going to be my major suggestion for them.
Thanks, Atul. Over to John.
Thanks very much. I just want to make a quick comment on the previous question. I think the CRPS question is now being very well answered. When it comes to flare-ups, there is a bit of a scientific approach, if you will, in terms of inflammation. So if you remember that slide about the big drivers of inflammation, and I think our panel touched on many of them just a few minutes ago, whether it's stress, poor sleep, inappropriate amounts of exercise, either too little or too much, or the wrong diet. When you look at these different drivers of inflammation, you can take a stepwise approach. Let's take an example. So of those four, exercise, activity levels, is the most of a double-edged sword. If you overdo it, you'll pay the price, and nobody wants to feel that. And so when you think about some of my patients who are so easily able to flare, they're always just on the threshold of flaring no matter what they do. I often focus on some of the other drivers of inflammation that are very unlikely to flare them. So for example, whether it's the relaxation response, which helps deal with stress, that's a very low risk approach. Similarly, when it comes to improving your diet, reducing the amount of junk food, taking in more compounds that have anti-inflammatory properties, that's also a relatively lower risk. So you often focus on the lower risk approaches first, bring down the total level of inflammation, and then you take on more and more adventurous risks, if you will. And so that, I think, is an important approach. And the last thing I would say on inflammation is there's always going to be moments where we have to perhaps go to a wedding or a graduation and we overdo it and we can't pace. And that's understandable. At the same time, keep in mind that the immune system, if it's constantly being triggered, it has a lot of difficulty relaxing, just like we do. And therefore, you don't want to be flaring yourself up so much that it never gets to relax. Retraining the immune system, for example, to be able to do more activity, takes a significant period of time. In animal studies, often many weeks or even a month or more. Dr. Tanguy?
Could you imagine this team here actually running a pain clinic together and supporting people? I would be just blown away to have such a group. Fortunately, you're all on my speed dial, so it doesn't matter. Look, last question we're going to go to, and then we'll let everybody get out of here. We still have a few hundred people watching, and we're looking at hundreds that have tuned in today. Amazing. So the next question is a bit about cannabis. First of all, yes, cannabis can be addictive, but the question about whether or not CBD specifically can be addictive is very questionable. Right now, my answer is simply no. There is absolutely no evidence to suggest CBD can be addictive. None. There's ample evidence that THC can be addictive. There's another comment on Twitter that cannabis use disorder is a made-up term and it doesn't reflect addiction or some stuff like that. Cannabis use disorder is a very nice step-by-step process for practitioners to help diagnose and communicate in the same language what they're looking at. It absolutely represents addiction. And for the vast majority of people, this is still the terminology that's being used. There are some small factions out there that still want to use dependence or DSM-4, or just would like to use addiction as addiction and nothing else happens. But I'm not into self-promoting. The focus is really simple. If you're diagnosed with addiction, that's not a terrible, stigmatizing, horrific thing. That just means that it's another diagnosis and another medical treatment that we have to deal with. It's not horrendous. The other part about cannabis was about the age thing, and I'll get some responses from the rest of the group. You mentioned research reveals that there are no changes in intelligence by cannabis users. Question is about concerns about cannabis use before the age of 25. Do they still apply as the brain is developing up to this age? I'm going to pass this over to Dr. Kular first, we've sat on a few different cannabis panels, and then I'll see if anyone else wants to tackle it, and I'll try to finish it up. So, Dr.
So, I think it's, you make a good point. I think, to me, I always view cannabis like any other medication, right? If we look at some of the other medications, we look at pain, they're vastly more addictive. Opiates, benzos, these sorts of things. It just isn't structured like one. So to me, the issue more, and you're right, 100% agreement with the CBD. CBD is fine. It may not work for you, and you should talk to your treatment team, but it's a low risk treatment. And I think Dr. Pereira nicely outlined like what are low risk interventions versus higher risk interventions. And to me, CBD from a financial point may be high risk, but from a treatment point may help. If it helps, it helps. But I think the other key thing that I would like to make is my issue is not really with cannabis use disorder, except in very rare cases. And I feel that it's frustrating that everything gets labeled like an opiate, right? Including ketamine now, right? So I think the thing is cannabis the optimal thing for your pain concerns is more my question. And what type and how? Because, for example, if you have certain types of anxiety, cannabis can be very useful. If you have certain other types of mental health issues, often like bipolar disorder, it's probably not the best option. So to me, I put it in the whole pantheon of things in the toolkit. And I'll pass it over to John.
Perfect.
Well, thank you very much. I just wanted to say something very briefly regarding CBD and THC. And I think this has already been mentioned before, but it's worth repeating. One is not able to get pure CBD in the Canadian marketplace right now unless you are doing research studies. And therefore, when you think about cannabis oils, for example, inhaled cannabis, when you purchase a predominantly CBD-based product, that's what you're getting, predominantly CBD. You are, however, getting some THC. So that's the first comment. The second comment has to do with the fact that there is some controversy right now, and you could do a quick Google search and you can see regarding how accurate the percentages are listed on the bottles of some companies. And the reason I bring this up is twofold. Number one, if you are someone who's very THC sensitive, then be aware that a relatively CBD-based product may have some THC, and you should know that. And then number two, when it comes to the law and driving, or has to do with THC use in workplace. For example, some patients work in the oil fields, they work with explosives, they go to urine drug tests and so on. Just be aware that sometimes that small amount of THC can test positive. Dr. Tankett?
Perfect, thank you. I'm going to bring it back to the original question is the under 25. So we know males, our brains don't develop to 25. Some would argue they maybe never develop. Females, usually at the age of 21, hence they're always ahead of us. So the end of the day, the bigger concern about early use of cannabis is increased risk of childhood onset schizophrenia. That doesn't mean that cannabis causes schizophrenia. That causation correlation thing has been really hard to pull apart. I've been in some interesting Twitter conversations about it. I'm not going there. But what we do know is that it increases the risk of early onset schizophrenia. And we do know that the outcomes and prognosis is much worse the earlier you are diagnosed. If you're diagnosed at an early teenage years, the outcomes are not very good. So that's one thing. The second thing is there's some evidence to suggest that it may increase risk of other mental health conditions such as depression, anxiety. The problem is it's really hard to suss this kind of stuff out and tease it out versus like that intelligence study. Initially, we thought, oh my goodness, cannabis is tanking people's IQ, which IQ is supposed to be stable. From an early age to elderly, your IQ shouldn't really change much. To see drops correlating with more diagnoses was concerning, except there's so many variables that nobody really looked at, and twin studies didn't show it. This is probably similar here, is that if there's something called a 2-hit or 3-hit hypotheses. If you have cannabis and you have a predisposition to something and they both come together, then bad news occurs. And so you may be increasing risks that are unnecessary to increase. But we don't have a lot of the answers. And that's truly the answer that we have. It goes back to the theme of any cannabis lecture. We simply don't know yet. We have a lot of hypotheses and we have a lot of data that we can that is all observational. So it's out there and we collect it all and we try to tease through it and determine what it all means, but we don't always have the right answers. With that being said, what a way to finish. We don't know.